Welcome to GW Integrative Medicine, the podcast about disease prevention and health promotion from the Office of Integrative Medicine and Health at the George Washington University School of Medicine and Health Sciences.
I'm your co-host, Dr. Misha Kogan, Chief Medical Officer at GW Center for Integrative Medicine and Associate Professor of Medicine here at GW.
And I'm your co host, Janet Rodriguez. I'm the office's Administrative Director. Today, we're discussing trauma and adverse childhood experiences, or ACEs, with Clare Anderson. She recently retired as Senior Policy Fellow Emeritus from Chapin Hall, a policy research institution that focuses on child welfare and family well being.
Clare is a national expert on child welfare policy and practice, and a national thought leader on economics and concrete support. She was among the chief architects of the effort to address trauma, adverse childhood experiences, and toxic stress in children, known to the child welfare system.
Also joining us for the conversation is Dr. Michelle Clausen. She's a nurse midwife researcher and fellow with the Primary Care Research Training Program and a postdoctoral scholar here at GW. Her research focuses on developing interventions that incorporate trauma informed strategies and spirituality to improve health outcomes.
Clare, Michelle, so wonderful to have you. Welcome to GW Integrative Medicine Podcast.
Thank you so much. It is a delight to be here.
Thank you.
Always good to see you, Michelle. What are adverse childhood experiences or ACEs, and where did the term come from?
Well, I'll dive in there. Back in the 90s, Dr. Folletti was looking at health outcomes in an obesity clinic and really began to try and understand root cause. Did some really fascinating surveys of the folks who were in his clinic and began to identify 10 or so adverse experiences that were happening in childhood that seemed highly correlated with longer term health outcomes. And those 10 adverse childhood experiences really fall along the lines. There are about 5 that relate to child abuse and neglect, and 5 that relate to things that are happening in the household, like an incarcerated family member, someone who has a mental health or a substance abuse problem, divorce or loss of a parent. And from that original survey work, there is now an enormous body of science that helps us understand how early adversity is associated with and causal for longer term health outcomes, as well as outcomes related to education attainment, long-term productivity. But we're also beginning to understand how positive childhood experiences and other resources in families, in communities, and at the macro level help to really mitigate long-term poor outcomes and put folks on a trajectory towards health instead of away from health. Michelle, I don't know if you have anything to add or, think about, where the science is today.
Yeah, I think you did a great job explaining all of that. I like to emphasize for people who are not familiar with the term that it's these specific experiences that happen before the age of 18. That's something that I think can be very profound when folks who are not familiar with it look at the ACE questionnaire. I think another thing that is interesting to note is a lot of the questions, they're quite simple in the way they're put out, but actually simple in the wording, but pretty profound in its impact. And I have found throughout using the ACEs questionnaire and research, I am humbled by how many folks, both patients and providers, have not explored these simple questions within themselves. So even though it might seem simple, the 10 items, they cover a lot, but not everything. But it's pretty profound when I see people or talk to people who have taken the ACEs questionnaire, kind of what they come away with A lot of times folks saying, you know, I've never even thought about something like this, or I've never been asked. And then the other thing I'd say is you mentioned so much, and I think we'll talk a lot about, there has been an effort, particularly in the States, an emphasis to kind of stop or mitigate that first ACE, to stop this cycle of adversity that we're seeing. And I think we're seeing a lot of interesting stuff happen with that. Because I work primarily with women and birthing people, I'm really interested also in folks that have already experienced ACEs, who tend to have maybe missed those interventions, and who are dealing with the effects of ACEs, particularly in a vulnerable time like childbirth, and getting ready to parent a new generation. So I'm really interested in what you think in terms of what we could do for folks who have maybe already experienced these things and are being called to usher in new life and kind of build their own family.
Yeah, you know, we're learning a lot about that. My focus over the last 3 or so years before retiring was really on economic and concrete supports as a strategy to reduce child abuse and neglect, which are 5 of the 10 adverse childhood experiences. And while that science, you know, spent a lot of time behind the paywall, we tried to really bring it out and help people to see it in its entirety and situate it next to policy choices that states or the federal government can make. And what we really found by doing a deep dive into the evidence is that economic and concrete supports, really money, policies that resource families, particularly families who have limited access to resources, that the child abuse and neglect goes down when families have adequate resources to meet their basic needs. And that actually is being empirically shown additionally at Stanford, the RAPID survey, Phil Fisher's lab. He began surveying parents during the pandemic about access to resources, and found that when families were experiencing financial difficulties, that psychological distress went up in the parent. And then on the downstream of that, they saw emotional or behavioral difficulties on the part of the child. So we're seeing sort of how the family stress model that starts out with economic difficulties really empirically or you know, practically in the family leads to this sort of cognitive load, psychological distress, less warm or nurturing relationships, more conflict, and then this higher risk for child abuse and neglect. So we're really seeing how all these connections come together. I also want to sort of highlight Dr. Wendy Ellis's work at the School of Public Health at George Washington University. She showed us how adverse childhood experiences are linked to these more macro level challenges in communities that are often driven by inequality or lack of equitable access to resources, adverse community environments, poverty, discrimination, lack of economic or workforce opportunities, poor housing, violence. So this interplay that we tend to sort of blame parents for or blame folks for having challenges, really we're beginning to understand that these are sometimes policy choices that we're making, or that we have other options. We have these more positive things that we could be doing in the lives of families and communities that would or could off-ramp childhood adversity in ways that I think are becoming much clearer to us today. And Michelle, you're probably doing a lot of work at sort of that really sensitive time at the time that children are born, and that early postpartum period of that attachment and that early dyad. I wonder if you could talk about ways that you're seeing that we could really be strengthening that bond and reducing stress in the lives of families at that really pretty sensitive time.
Sure. And you talk a lot about the concrete, and I kind of talk about the opposite, especially when it comes to things like spirituality being an intervention. I mean, I do think it's becoming more concrete in the research, and I think it's becoming a valid variable to consider in outcomes. But I do think an option that should be explored that hasn't been is fostering things like spirituality in folks that we know have a high risk ACE score. I mean, and even stepping back, identifying those folks. For instance, in pregnancy, early in pregnancy, identifying folks who may have a high risk ACE score. There's really nothing to my knowledge being done like that. And then once early identification of those who might be at risk, for things like poor bonding or poor attachment, we can start, even basic things like teaching folks to have more autonomy in their care, ways that they connect to the fetus. There's a lot of evidence that shows that if you can encourage the mother, birthing person, pregnant person to engage in their own care, to connect with their fetus while pregnant, that they're more likely to form stronger bonds, more likely to be able to be available for the growing infant and child. So there's lots of ways we can integrate and include the patient in their care, which I think is very powerful. I think that's not uncommon to the midwifery model of care. So I think here's a plug for midwives, why we need more of them, to encourage this type of really collaborative care, where autonomy is kind of sacred, where shared decision-making is encouraged and not feared, and it's not punitive. And inviting people to be empowered by taking care of themselves and their growing fetus and baby. So I think that's really important. I think identifying what's, when it comes to spirituality, I'm currently doing G Wishes at GW ISPEC training, which is just encouraging clinicians and healthcare providers to integrate spiritual care assessments at any point in time when we're meeting with a patient. And it's really eye-opening. And Misha, I don't know if you know Dr. Polkowski. You should, yeah. And, her work is really about, identifying this as an ethical consideration, that we should all be taking account someone's spirituality and making a spiritual plan for them, if that's important to them. And that can mean it doesn't have to mean religion. It's not necessarily connected to religion. It could be connection to community, family, nature. And we know, and there's evidence that shows that those who have high spiritual well-being in pregnancy are more likely to bond well with their fetus and baby, more likely to have stronger attachment and bonds, even in the presence of things like early childhood adversity.
Well, one of the things that you're talking about here, and we kind of previewed it, is just asking people about what's happened to them, and what their coping mechanisms are, right? Spirituality is certainly a high on the list of ways in which folks center themselves and regulate and cope with the things that are inside, because it really connects you to something that's greater than yourself on the outside. I think that's part of how all of us try to point our health in a really positive direction. Social supports are really high on the list of ways in which disease burden is reduced, that new parent historically, new parents really thrive when they are surrounded by a community, whether it's a spiritual community or a community of like people, or a community of family who are supportive of them to really reduce the burden, both the real burden of caretaking for a child, but also the more internal burden of being alone in what is such a new endeavor, which is raising a child, which is, interestingly enough, we find that the birth of a child is the time in a family's life where they have the least access to resources fiscally. It is an economic shock in the lives of families, to bring a new child into the world. And that makes a lot of sense when you think about formula and clothes and all the things that have to go into bringing a child into the home. And so understanding this interplay between community and spirituality and access or lack thereof of resources makes this postpartum time, I think, a time where we could be creating policies and community response that is attuned to this real time in a family's life that is quite challenging. Sometimes it's exciting and new and wonderful, and at the same time, I think we underestimate the kinds of resources that are necessary to really help families create a nurturing, warm environment that is attuned to the need for self-regulation and attachment.
One could make an argument that the birth is the main trauma, right? And that in that sense, then I think some degree of ACEs is a universal human experience. And yet, think of it this way. I'm just going ethical and spiritual here. Just flow with me for a second. So think of it this way. We don't have any infrastructure in this country that universally accepts the fact that the trauma is a human experience and it needs to be part of the medical system. There's an idea that psychologists will take care of all this, but we quite know from multiple different works of different experts that trauma first and foremost is a body experience, and it gets locked and it's often not getting released, and then we have generations upon generations, patients presenting with somatic illnesses that are clearly started there. And yet, there's no recognition. We medicalizing treatment of these patients. We give them drugs, more drugs, and then we give them procedures. And often they not only not benefiting from this, they keep continuously getting worse. I mean, Claire, you've been at this for a long time. Is there any political sense of recognition that we have a complete mismatch between the sort of model of care and what's actually happening out there in the world? And if we do have that, I mean, what should be the us in the trenches as a physicians advocating for?
I think that's a really insightful and important question. I don't think that we have good alignment between our medical model, which is quite deficit based and reactive, and recognition of early adversity as an important and causal driver of long-term health. I think Nadine Burke-Harris in California has come and Bob Sege, both have come very close to trying to elevate this mismatch and try to find ways to bring the health system into alignment. Mm-hmm. Nadine Burke-Harris and Jack Shonkoff, I think, at Harvard in the Center for the Developing Child, I'd also add to this list, of really asking families about early adversity, both of themselves and their child, and then trying to build care plans that are focused on ameliorating or addressing the dysregulation, and thinking through the ways in which we can integrate. I mean, that's what we're talking about here, integrating medicine and other strategies. You know, we don't talk a lot about in medicine that first line treatments are quality sleep, great nutrition, exercise, social connections, having access to resources, and really understanding what's Bruce Perry, what happened to you, not what's wrong with you. And really starting there. I did a book review of Childhood Disrupted in Health Affairs, gosh, 10 years ago at this point, about trauma in early childhood. And I said at that time, no physician had ever asked me my ACE score, never. And I'm a high user of the health system, as you well know, Dr. Kogan. It's kind of shocking, really, because it's a driver. I'm very clear that my health is rooted in my early experiences, and I think that's true for all of us. I think it's also important to talk about the relationship to our macroeconomic policy context. We know that policies like Medicaid, the Supplemental Nutrition Assistance Program, the Women, Infants, Children Program, are associated with reductions in child abuse and neglect. So the more resources that families have available to them, the less likely we are to see child abuse and neglect, which are 5 of the ACEs. So it's actually far more integrated than just medicine and health. I think we have to look at this very holistically. Dr. Ellis helps us understand community. We've got to be more attuned to ourselves and our communities, our health system, and our macroeconomic policy context as a comprehensive whole that drives health and health outcomes. And in part, we have to do that not just for ourselves, but because it's very costly when we don't. The downstream economic burden of not getting ahead of adverse childhood experiences is enormous. And we can talk a little bit about that. But we tend to worry that if we focus on prevention, that it's too costly and that we can't afford to do it. But we pay on the back end of it anyway.
Yeah, we pay a lot more. We pay horrendously more because we are applying tools at the end point when problems show up that are way more pricey than prevention, and they don't work. So it's not like you apply them once and then you fix the problem. You keep applying them and they're not working because you're applying them wrong, right? Because we're medicalizing in our healthcare system, over medicalizing every single treatment for this behavioral issues, and then we're wondering, why is this not working? Well, it's not working because we're not really trained. The healthcare system is not trained how to appropriately do this. And, okay, so now at least I would say, to respond to your point about physicians not asking about ACEs, I think we're doing a little bit better. I think there's more teaching of students and all. But, okay, so we told the student they're ACEs, but we're not telling them anything how to fix it. We're not teaching them. We're not. The fact that only some schools are fully educating students about what to do about this from non-medical perspective is there. Michelle, with that in mind, you've been in a major academic institution for some time. What is GW doing around this? I mean, are you seeing that we're moving somewhere, or is our own institution is in a bulk part of doing not much?
I would like to say that we're doing stuff because I'm a postdoc there, but I just want to go back to a few things really quick that you said. I to just kind of bring this back because I'm thinking, Claire, as you're talking, this just really instills how important investing in the pregnant person, how important it is to prevent I would say to prevent kind of this cycle of adversity. And that should be where a lot of the money and policy is taking place, which it's not. I mean, we're seeing the maternal mortality, we're seeing morbidity. And Misha, you mentioned that birth is traumatic. Yes, but it shouldn't be, and it shouldn't necessarily be traumatic for everyone. In the States, with a C-section rate now 30 to 40%, with rates of what we're calling obstetrical violence rising, with growing distrust. Yes, birth is becoming more traumatic, but it doesn't have to be like that. And it's not always like that. And I spent at GW when there was a really robust collaborative midwifery practice, which is not quite there anymore. We saw how birth can be restorative, redemptive. It could be healing. It could be a time of great transformation. So it definitely does not have to be like that. And I think the rhetoric is that birth is such a violent, traumatic, fear-based thing. And I think it's because our model perpetuates that. And I think we need to see policy changes that are, completely changing the way obstetrical care is handled here in the US. And, that includes expanding to investing in things like birth centers, which we know are evidence-based and have great outcomes, and investing in supporting midwives. We have birth workers who are leaving at an alarming rate. And so what's going to happen in 10 to 20 years? So, Claire, thinking about the concrete where you focus on, there's so much need, even right before birth. So what I think, I can speak to what GW is doing, except for the work that we're doing at the Resilience and Wellbeing Center, and our work on ACEs. I have a project going on with Dr. Lee Frame and Patrick Core, where we're looking at ACEs among students entering healthcare professions. And it's been really fascinating. So we basically, gave students entering who are in medicine, nursing, PT, OT, and PA, and we gave them the ACE questionnaire. We gave them a well-being assessment, and then I interviewed them. And the results from that, and the hypothesis here, just to back it up, is my hypothesis, and there's some research that supports this, that folks who enter healthcare professions probably may have a higher than average ACE score. And so I will say that our results confirm that. And when you look at the ACEs by individual questions, which is a whole nother world of, right, when you look at the ACEs, we saw well above average in every category except for, which wasn't surprising, I think it was separation or divorce, and living with someone who was incarcerated. But things like sexual abuse, over 20%. I mean, the numbers, when you look at it, and Claire, I don't know if you feel this way, but every time I look at the individual breakdown of ACEs, that's when I start to get chills, because that's really telling a different story.
I'm not surprised. I think it makes a lot of sense. It's sort of this idea of a wounded healer, that you can,
Sure.
that your soul after the negative experience is drawing from that experience to help others. I mean, I can definitely relate myself. I had enough childhood traumas growing up, and I ended up doing this. It makes a lot of sense intuitively. So it makes even more sense than we should be at academic centers. We should be teaching students with that in mind a lot more. We should be helping them to learn their own trauma and move them forward. When we had a integrative medicine track, we made every medical student in the track read the Body Keeps the Score book, which I think is, at the student level, is probably one of the most fundamental books, and I'll make sure we have a link to that book, because I still think it's a great book and a great concept of sort of understanding why somatization happens and why body locks the trauma, and what can we do about that.
And can it be used as a professional development tool? Maybe I learn about ACEs and that, I learned that, trauma night surgery is not going to, really be for my long-term goals the best thing for me. Or, it pushes me and inspires me to go into a place that I, never thought. So I think it could be used on many different levels. Not just like patient outcomes, but professional identity formation, professional development. And I think universities could really play a huge role in shaping the next generation of healthcare providers.
I promised myself I'm not going to go there, but I do have to mention this. So you know that the trauma is primarily mediated by the endocannabinoid system. And so, some people are wondering that this country has this horrendous, abuse of different substances, in part because we created a mass deficiency nation. We by not addressing these issues at its core and getting a lot of young adults to a point where they facing the world on their own and they designing self-mitigating, self-treatment strategies, often they're not efficient. So they default on things that make them feel better instantly, and the cannabinoids, particularly high intakes of a highly intoxicating cannabinoid, does address the trauma symptoms. We know that. And I'm not necessarily happy about it. I'm bringing this up more from the perspective of, look, I mean, we know the problem is there and we're trying to handle this, we're mishandling this, and then we often end up blaming society that we have too many addicts. Well, it's our doing on a grand scheme of things. People out there trying to fit the gap that's missing.
And what we see as people are trying to fill that gap for themselves and using substances during pregnancy, for example. And then we organize the response to that more often than not as removing the infant from the home, from the parent. And we are recreating that trauma. And as a nation, I think we have got to find new solutions for addressing maternal substance use during the time of pregnancy and postpartum that allows for us to maintain the bond between the infant and the birthing parent, lest we continue this cycle of removing infants and increasing that adversity, and breaking that dyad. So we've done a fair amount of work recently that actually, let's pause and let me back up there. So we have, as a nation, begun to look more closely at this really sensitive moment in the lives of infants and parents. And I think are beginning, just very nascently, beginning to reconceptualize how we might keep infants with their parents and address safety concerns, but be very attuned to this dyadic bond, because lifetime safety is also important. The moment of safety at birth and when infants are very young is important, but our lifetime safety is also important as well.
That makes so much sense. And I bet there's a reciprocal kind of long-term effect for both mom and baby with efforts on that part. And I'm just thinking, as you were talking, like attachment theory, everything we know from Bowlby and everyone else who have expanded upon that work, and how critical the attachment bond in the early, days, weeks, years, and how critical that is for identity formation, future healthy attachments, overall health. So it's very powerful.
There should be some positive data, right, in cases where families able to manage ACEs well. I mean, I'm presuming there has been studies of what could be the actual, I don't know if it's an ideal case scenario, but when you do manage the ACEs well, what ends up happening? Can either of you comment? Because I'm looking for a future here, right? I'm looking at what can we hope for, and there must be some positive examples, or I hope there are.
Oh, absolutely. Without a doubt. There's a new systematic review of longitudinal studies looking at positive childhood experiences. And the set of positive childhood experiences were associated, I'm just going to look here at the study, associated with reduced rates of depression, substance abuse, delinquent behavior, risky sexual abuse, persistent insomnia, and lower inflammatory markers. So back to your statements earlier. So we do have some evidence that positive childhood experiences improve health outcomes and functional outcomes as well. So, talking inside the family about things that are positive and challenging. There is some look at reduction in heavy drinking and smoking, reduction in chronic conditions, improvements in annual household income. So we actually do have a very large ray of light here that help us to begin to understand the ways in which we can mitigate and improve long-term health and well-being.
So it sounds like we're more than our challenges.
That's right.
It's well put.
Absolutely.
I mean, one can argue that if ACEs are universal human experience, then they're probably given for a particular reason. And the fact that the birthing process has to go through this complexity of anatomical changes and shifts, and more often than not, it does carry some, if some component of trauma, I think points toward the kind of universality, but more importantly towards, I think, multitudes of layers. And I think one of the layers is, we come in here struggling, and I think that is the spiritual underpinnings here. We come struggling, and we solve our journey, and that's a part of the path. And again, I'm going back into healthcare systems, saying that maybe the ACEs should be looked upon more as a societal phenomenon, not necessarily part of just healthcare system. Maybe it should be a lot more integrated into the cultural awareness, and maybe it's not a healthcare system that should be only dealing with it. Maybe it needs to be a lot broader, because it is a broader phenomenon.
There's absolutely a broader group of systems here that should be thinking about how to mitigate. The education system is one. Early childhood system, child welfare, really all of them. again, I said this earlier, this really is a holistic opportunity for us as a society to address adverse childhood experiences. Dr. Sege, I just want to read the positive childhood experiences that they looked at and the return on investment. I talked about the downstream costs earlier. They looked at a number of positive childhood experiences and found these more positive outcomes that I just identified earlier: lower inflammatory markers, higher income. And those were: an adult made you feel safe and protected. You felt like you belonged in high school. You felt supported by friends. At least 2 adults took interest in you. And that pace has been consistent across time. Is there one adult or 2 who felt like you were special or saw something in you that you felt was important? You felt like your family stood by you. You enjoyed community traditions, and you felt like you were able to talk to your family. And when these are found, and let me just scroll down to the bottom of this, like the return on investment here was pretty significant. And let's just hold on just a second. In the 4-state study, the presence of 3 or more positive childhood experiences was associated with an annual economic value of $216 billion based on lower chronic disease burden. So we actually do see this return on investment of helping people to feel connected to others and helping our systems be responsive. That's a lot of money.
It is indeed. So, if an adult wanted to take the ACE questionnaire, where do you suggest they go?
Well, that's easy. I mean, they can Google ACE questionnaire and they'll be able to find it free. A good resource that I look a lot to is ACEs Aware out of California. Has the ACEs questionnaire and lots of downloadable content. They offer free training for those. It's more specific to healthcare workers, but I think could be beneficial for many people just looking to have find more information. And then there's a lot of information about ACEs on the CDC too.
There's a great blog that tries to keep up with the literature and translating it in a way for pretty much anybody to understand. It's called PACES Connection, and that's at pacesconnection.com. I look there a lot to know what's happening out in the states around system responses, as well as looking at recent research.
Well, I think we're getting close to our time, so maybe let Michelle and Claire, if you guys have anything last moment you want to share, maybe last part of wisdom with our listeners.
I mean, I just learned a lot from Claire and just being here. So I'm so appreciative that folks are working on this and taking this seriously. And I think it's a sign too that collectively we are moving to a place where we're acknowledging that it's beyond physical. and that whether we think about generational stuff that's passed down or things we've directly gone through, that it matters, and it's not going to go away. And so I think we're entering a space where people are acknowledging that we're going to have to honor it.
And I guess I would end with a description of hope, right? There is a lot of science that helps us understand what happens when you do have adversity in early childhood. But now there is a growing body of evidence around positive childhood experiences and other ways in which we can support our systems and individuals to have a healthy lifetime trajectory. And that is thrilling because it gives us this window into how to, for ourselves, think about our own self-regulatory processes and our health care and well-being and resilience trajectory. But it also gives us ways in which our systems can begin to reorient around health and well-being.
Well, thank you, Claire. Thank you, Michelle. It's such a great place to end. That's all the time we have today. Thank you so much for joining us. And we'll bring you back at some point.
Thank you so much.
Thank you.
This is the GW Integrative Medicine podcast from the GW Office of Integrative Medicine and Health.
I'm Dr. Misha Kogan.
And I'm Janet Rodriguez. Thanks for listening.